Hi, my name is Dorothy Hendricks. I'm one of the pediatric ophthalmologists at DuPont Hospital, and today we're going to talk about some common retina and orbital conditions in children. Okay. So this is just a summary of the conditions that we're going to go through, a summary of some various retina topics and orbital topics in children. I will tell you my bias is that I prefer the orbital category a lot more. Retina was never my fun part. But there are some, common retina conditions in children that we're going to talk about today. First of all, Leber Congenital Amaurosis. And this is one that I really do think about when I'm seeing children, especially children who come in with a history of nystagmus, poor vision, and every other part of the evaluation is essentially normal. And here, this is then what I kind of fall to on a differential diagnosis. On your examination, these children are typically hyperopic, characteristic for their age. They have a sluggish pupillary response, and they have a significant incidence of other neurologic and renal disorders. The fundus appearance has a lot of variability, can even be normal. And so that can really make this diagnosis a little bit more of a challenge, but something that we do think about. Or there can be an RP type appearance with bone spicules, attenuation of the vessels, and some waxy disc pallor. Other findings that you can have are these white marbleized, these white dots, which you can also see in the retina. How do you make a diagnosis then of Leber's if the rest of your evaluation to this point has been normal? Is with an ERG. And so what you'll find is that it's almost essentially completely extinguished. The thing that we always have to consider when we're doing various workups in children is that a lot of these tests require sedation. And so, you really want to try to do all at once if you can. So if I feel like I need an MRI or I need an ERG, if I've really got a high suspicion, we will try and coordinate and do all those things at once so as to minimize the number of times we're sedating these children to do these procedures. On histology, you'll find diffuse absence of the photoreceptors, both the rods and the cones. And the genetics of this condition, it has been linked to both a chromosome 17 and chromosome 1. In terms of other conditions, which also could have an RP-like appearance to the retina, we're going to talk about two here. Refsum disease, the first one. This is autosomal recessive as well. There are two forms, an infantile form and an adult form. With the infantile form, it is a disorder of all the peroxomal biogenesis, whereas in the adult form, it's only a single one. And typically what you'll find is elevated phytanic acid levels. And this is important for the adults, unfortunately, not as helpful in the infantile form. And again, what do we see here on examination? This is one where we classically see RP-type fundus. You'll have some waxy pallor to the disc, skinny little vessels. And this fundus photo doesn't show it, but often you will have some bone spicules as well. These children tend to have nystagmus secondary to severe vision loss. They can develop cataract. And again, the ERG is severely diminished or absent. Again, these children, you kind of really with children have to try and put the whole picture together when you examine them. And, what you'll see with these children is that they often have other craniofacial malformations, very severe hypotonia, mental retardation. They can have bleeding diseases, and as well as liver dysfunction and even severe deafness. And unfortunately, the infantile form is typically fatal by the second or third decade. In the infantile form as compared to the adult, what you'll find is the phytanic acid levels are only mildly elevated and can be even normal, and treatment with supplementation does not help. The adult form, on the other hand, have very high phytanic acid levels in both the blood and the urine, and treatment with dietary phytanic acid restriction can be helpful, but it really does not often help to improve the eye vision loss or the hearing loss. It just this kind of stabilizes things. Again, here, these adults tend to have some systemic conditions of ataxia, weakness, peripheral neuropathy, muscle wasting, and, of course, the deafness. Another condition that we find which can present with RP-like picture of the fundus is Bassin-Cornfeld syndrome. And here again we have a pigmentary retinopathy, and this is a little bit different because they tend to have really larger and closer pigment clumps than in the other RP-like conditions. And they can also very classically have some peripheral white dots. These children also often have ophthalmoplegia and ptosis. Systemic findings, again, they can have spinocerebellar ataxia, acanthosis, and fat malabsorption. And here, treatment with vitamin E and A replacement is essential. I felt like we needed a little break. This is my son, Henry, on his 3rd birthday. He just got a bike. My partner, who normally gives this talk, Dr. Salvin, is currently traveling in Africa. And so he had pictures of various animals in here. I really didn't think I could add much to those, aside from saying this is a giraffe or an elephant. And so I threw in a few photos of my kids just to kind of break things up a little bit. Okay. Achromatopsia. I will tell you that I see a lot of children who come in for evaluation on the spectrum of color blindness, that, very commonly parents come in concerned that their children are colorblind. But the incidence with I truly see children with achromatopsia is obviously much less. But it's very common concern. I think that, as a parent, you get nervous. Does my child just not know the colors, or is there an issue? Here with achromatopsia, different, this is autosomal recessive. These children have nystagmus, and they have no color vision. So it's a much different situation from the nervous parent who says, my child doesn't know their colors. They have very poor central visual acuity, and they're very photophobic. They really have a true desire to avoid the bright sunlight. Again, these children tend to be hyperopic, classic for their age. And what we would find, again, here is a profound reduction of your cones with a normal rod function on your ERG. In the complete form, your vision is really, really significantly reduced about the 2200 level. And in the incomplete form, there's variation from about 2050 to 2200. Fundus, again, typically normal. You may see a decreased foveal reflex, and bullseye macular changes can be seen very late. Again, on your exam, these children will have abnormal color testing, and your ERG will give you your diagnosis with a completely extinguished photopic response. Blue cone monochromatism is, on the other hand, an X-linked disorder. Here, this is a stationary cone disorder with color vision abnormalities. Vision ranges 20/60 to 2200. Again, our fundus exam is normal. And here, again, we will see the ERG with the extinguished photopic response and a normal rod response. One thing you may see on your fundus exam is that these children could have tilted discs. And obviously, genetics is linked to the X chromosome. Congenital stationary night blindness. Here, children will have normal to decreased vision on the 2200 level and markedly decreased night vision. They also have nystagmus and a paradoxical pupillary response. There are several different classifications of congenital stationary night blindness, and we're going to go through them here, those with a normal fundus and an abnormal fundus. When you think about those with a normal fundus, looking at the genetics of it, these are typically, you can have autosomal dominant, autosomal recessive, or X-linked recessive. ERG is, again, very helpful because it shows an absent scotopic response or even a negative ERG in the type 2 form. And then here, let me go to some other photos. So this is congenital stationary night blindness with the normal fundus, type 1, which shows a reduced amplitude of your cone response and an absent rod response. And type 2 shows the absent photopic wave and the absence of the B wave with a deep normal A wave. I have to say, I know you guys just took your OCAPs. I feel like CSNB was one that they really like to hit on, at least from my prior experience with OCAPs and boards, and so it's a good one to learn about. congenital stationary night glasses with abnormal fundus. And this is, one, because it's nice they have classic photos with Joubert disease. This one is autosomal recessive, and you characteristically see this yellow phosphofluorescent discoloration of the peripheral retina and these metallic flecks. And then it returns to normal after several hours of dark adaptation. And it's linked to a genetic mutation in the retinal S antigen, and rhodopsin kinase is identified. Again here, fundus albipunctatus, classic photo here where you have these discrete little white dots, but absolute sparing of your fovea. And that's the classic picture for that. Your ERG in this case will be normal once they've been dark adapted for several hours. And this is a disorder of your rod and cone cells. Another example of CSNB with abnormal fundus is fleck retina of Kandori. And here, again, it's autosomal recessive, and you see these very irregular but relatively well demarcated dirty yellow flecks, primarily nasally. The macula will be completely normal, and here your ERG will show a normal A wave and a reduced B wave. Accardi syndrome. I can say I do have one patient, a female, obviously, with Accardi syndrome because it is lethal in males. It's an X-linked condition. And this photo could honestly be taken from my patient. They have optic nerve hypoplasia with colobomas, and they have these depigmented areas, these lacuna of the retina that you see. They have infantile spasms and severe mental retardation. And this is just an MRI showing the absence of the corpus callosum and an anomalous disc that you can also see in Accardi syndrome. I would say more characteristically, this is really a classic picture for Accardi syndrome. Norrie disease. Norrie disease is also X-linked, and this results in progressive bilateral blindness. Common systemic associations are hearing loss and mental retardation, and unfortunately these children have bilateral retinal detachments within typically the first few days to weeks of life, and they get late corneal and lens opacification and ptysis by about age 10. And surgical repair is really unsuccessful. Fever is one that we do see and I think about more commonly because the characteristic thing for you with thinking about your boards and stuff, fever characteristically looks like ROP. And so they will kind of try and trick you that way in thinking, is this fever or ROP? And what you need to know is the history. Was this a preemie, low birth weight, oxygen exposure? And with fever, those things don't exist. These are full-term babies, normal birth weight, no other history of problems with the birth or the delivery. It's an autosomal dominant condition, but it does have variable expression. And, as I say, it looks just like ROP, that your vessels kind of come to a point and then you have incomplete, the rest of the retina is bare. There's no vessels there. So that's why it looks just like ROP. 3 stages that you see. The first, again, this peripheral, kind of gets cut off here, but you can kind of see our vessels come to an end and there's still more retina here. So you have this peripheral avascular zone. Then stage 2, you get neovascularization, and stage 3, attractional retinal detachment. Ocular albinism. Again, this is something that I more commonly see in my office, and there really is, as we learn more and more about diseases, there's such a spectrum that we find. I think, for your learning purposes in the textbooks, everything tends to be so black and white, and there's this type and this type, and, it's really what we're finding more so in a clinical setting is that there's really a spectrum of disease. And ocular albinism, these are the characteristic findings. Here we see the iris transillumination, and in this photo here you don't really see a good foveal reflex. It's hard to see here, but there's some, the nerve also looks hypoplastic as well a little bit. And then there's just no pigment in this fundus. You can so clearly see all of your choroidal vessels coming through. And again, a lot of ranges in visual acuity, and that depends on how much pigment there is in the retina. And you can go from 20/40 to 2200. I have 2 little girls who have this, who are both doing very well and about in the 20/40 range. And what you will also see is that there's an abnormally large number of crossed fibers at the chiasm. So they'll fail their stereopsis, and they have asymmetric visual cortical evoked potentials, although really this is a clinical diagnosis. You don't typically need to do that. I do refer all of these children, though, to genetics for their help in caring for them, and so that they can have discussions when it comes for these children to be having children of their own. Foveal hypoplasia is just incomplete foveal development. We can see it, as I mentioned, associated with albinism and also in aniridia. And on examination, you just see a decreased absent foveal reflex. Your ERG, however, will be normal. And that's because your ERG is really a representation of your whole retina. So your fovea, your macula, is such a small area that if that's the only area there's a defect in, you really don't find any evidence of it when you do an ERG. And PHACE Syndrome, that was always a good one to know, too, for the OCAPs. Joubert Syndrome. My partner Jonathan, who usually gives this talk, actually has brothers who have Joubert, one of whom, unfortunately, just recently passed away. And this can be sporadic or autosomal recessive. And systemic findings are episodic tachypnea. They have this very rhythmic protrusion of the tongue, ataxia, very low tone, psychomotor retardation, and dysgenesis of the or hypoplasia of the cerebellar vermis. Ocular findings, what you'll find is a congenital retinal dystrophy in about 50% of patients, and vision varying from about 20/60 to 2200. And here we'll have a flat or severely decreased ERG. They have nystagmus, they have colobomos, congenital ocular fibrosis, and this one child who we had actually also even developed retinal detachment. All right, so another break. This is my newest addition to the family. This is my daughter, Mary, who is now 5 months. And the reason I tend to be a little tired, last night the pager went off at midnight, and she decided to get up and eat at 1 and 4. So it makes things a little bit hard when you're working full-time. But I obviously chose pediatrics and love kids, and no different with my own. But it's a challenge when you're working. All right, Orbit. Much more fun, in my opinion. So hemangiomas. Inevitably, when you do your peds rotation, you're going to see a child with a hemangioma. It is the most common tumor in children, and capillary ones are more prevalent than cavernous. It's not usually present at birth, but just the first few weeks after. Sometimes there are some children who may have a little small something present at birth, but then it's usually the first few weeks after that parents are really like, oh, what is this? And they can grow to an unpredictable size through the first 6 months to 12 months of age. And usually what we see is spontaneous resolution by about 2 years of age, that, they'll start to see them slowly. The color will decrease. They won't be as heavily pigmented. They'll get a little bit softer, and then over time they will regress. That being said, there are children who need to be treated for this. Here are a couple other examples, one here and here. And so in this one here, the first signs of regression, what you'd see is this, this deep red, purple color would start to slowly fade. And that would be your first evidence. But why do we need to treat them? Because of amblyopia. So when you have this big hemangioma pushing on the eye, it can cause a significant amount of astigmatism and thus anisometropia between the two eyes. Prevalence ranges somewhere from about 43 to 60%. And you can also have occlusive amblyopia just from a lesion that is so big that it's forcing the eye closed. That tends to be a little more typical with upper lid lesions. And when we treat these kids, which we're going to talk about next, how we treat them and the options for that, a lot of this astigmatism usually resolves at least partially. But it may not be complete. And so even though your hemangioma with treatment has gotten smaller, we still, as a pediatric ophthalmologist, need to be following these kids, especially if the astigmatism hasn't resolved, because they will continue to need still amblyopia treatment. PHACE Syndrome is something to think about when you have children with really extensive hemangiomas. I did have one child who it was almost her whole face, or whole side of her face was covered with a hemangioma, and she had, significant findings on her MRI. And what you'll see are posterior fossa malformations, hemangiomas not just of the face and orbit, but in the liver, abdomen. You have to be very concerned about the airway here, arterial anomalies, coarctation of the aorta, other cardiac defects, and other eye abnormalities. Okay, so first of all, when to treat? Well, we treat if the hemangioma is so large that it's causing occlusion, or if it's a significant difference in the refractive error between the two eyes. If they're small, they're not affecting, the eye in those two ways, then we just watch them conservatively. Now, I will say that sometimes, even though they aren't affecting the eye, they still need to be treated. Some patients will have significant ulceration of the lesion. So, I've had kids with, they all get referred to us, and, maybe it's way up here on the forehead and it's doing nothing to the eye, but it's ulcerating, it's bleeding, there's problems like that. And so then they get treated as well. But for us with the eye, what we're looking for is either, occlusive amblyopia or anisometropia. And the newest, which I'm sure you are all very familiar about, treatment for this is propranolol, which has pretty much replaced steroids. I will say that in my experience, it was very rare that we did local steroids, that we did steroid injections, either in my fellowship or now out in practice. But we did use systemic steroids in conjunction with dermatology, helping us to follow these children. But now the newest agent is propranolol, and I would say that more often than not, this is the choice. Really, the dermatologist kind of goes over the risks and benefits and treatment options with these parents, but I would say that the majority of my parents are choosing propranolol, and we really see a profound effect. So, this is just some of the doses. Typically, and this may change over time, most of these patients, when they choose propranolol as an option, are still getting admitted, getting an EKG and followed for 24 hours on the propranolol to make sure that they don't have any bradycardia. If they do well, then they continue treatment as an outpatient. And I think that really the move is going to be even more likely for outpatient only therapy without that initial inpatient admission. And, as I say, these are the systemic complications that we worry about: bradycardia, hypotension, bronchospasm, cerebral hypoperfusion, and PHACE Syndrome. That being said, I will say that all of my patients who have done this have tolerated it really very well. And, the studies are showing close to 100% response in patients treated, and a greater than 50% decrease in tumor size, and over 60%. And the other thing that's profound, the reduction in the astigmatic error. So it's really been a wonderful new treatment option. And now, of course, the next thing is, can topical timolol be effective as well? And the early studies are showing promising results, but it's a much slower response. But that's on the horizon. Lymphangiomas. Okay, so that's going to be our next topic here. And you could kind of see that maybe this would be something you could think, could this be a hemangioma? Is it a lympangioma? But a couple of things are going to help clue you in. First of all, the age of the child. Hemangiomas don't suddenly pop up in a 4 or 5 year old. They've been there since birth or close to it. While some of these will present at birth, it's more likely later on. They do not regress over time. And what typically happens is they can sometimes be small, insignificant, and these children will get some sort of cold URI, something like that, and it really blows up and gets enlarged. And they get what are called these chocolate cysts within the lesion. They're very difficult to excise as their margins are very poorly defined. I've done a few, and, you just feel like you keep going and keep going and keep going. Really, it's only, I've only done it when it's been basically kind of bulging out of the conj, and, it's preventing full closure of the eyelid, and very cosmetically unacceptable, plus, then there's concerns with the cornea drying out and issues like that as well. Another little board spot is that these, do not expand with the Valsalva as varices. Initially we will watch because, as I say, a lot of times these are small, inconsequential, and then what happens is, the kids get a cold, they get some hemorrhage in it, and so first we'll watch and see what happens if they'll just kind of, shrink down to an acceptable size as the hemorrhage resolves. Things that you can try medically are systemic steroids. It's variable. Some kids will respond pretty well and some won't. Amblyopia management, and then the surgical management, but as I say, it is a challenge. And there's also the risk that during it you can have, either during the surgery or after, some continued hemorrhage. But really, when you're doing this, you just feel like there's no end in sight, almost. So this is my son's 3rd birthday, just to take a break again. And we had it at this place called Jumpers, which is fun for any of you people who have children. It's basically a facility with indoor moon bounces, and the kids love it. It was first birthday party we ever did for him, so they had a blast. Dacryocystocele. Again, something you will definitely see during the course of your peds rotation. And what you'll see is this tense blue-purple kind of swelling right below the medial canthal tendon. Typically present at birth or very soon after, get calls, we're ready to discharge this kid, but now we notice this kind of bulging blue mass right here. Typically what happens is you get an obstruction with a nasolacrimal duct obstruction. You have an obstruction just at the end of your system. And with a dacryocele, what happens is you've got one at the top and one at the bottom. And so everything just accumulates right there. So this is just showing this. Typically with an LDO, you just have your obstruction at the valve of Hasner. And then with a dacryocele, you get one up top and below. So then all of the fluid and or pus, because these can commonly be infected, just accumulates here. I will tell you, I am pretty aggressive with these because no one really wants to take their newborn to the OR if you can avoid it. And so I'm pretty aggressive with putting some pressure right here on the lesion to try and decompress it. And more often than not, you'll have really pretty good success. If I decompress it and just clear fluid comes out, I don't proceed with putting the child on antibiotics. If I decompress it and, nice yellow-green pus is coming out, then I'll put them on systemic antibiotics as well. In general, what tends to happen when you decompress them here is that you've opened up the system up top. And so there's a method of exit for the material. And then I instruct the families to continue to decompress it at home and also try to do some massage to see if we can pop it open on the bottom as well. Sometimes with these children, you can't get it to open up on the bottom, and they'll still have, although you decompress the dacryocele, they may still have some continued symptoms of a nasolacrimal duct obstruction. That's fine, because you know what? We'll wait till 1 to do surgery for that, and everyone would prefer their 1-year-old going to the OR for tear duct surgery than their newborn going because they have an infected dacryocele. One thing we do sometimes do with this is, let's see here. Okay, well, I'll go back. As I said, attempt to decompress them manually. Antibiotics, I do that if they are infected. I will say, and it depends on where you're going to train, your institution. When I was a fellow, we would, one way that we would kind of avoid going to the OR is we did probe these children in the office or if they were admitted on the floor. And it's not the most fun thing to do to a child, but, they're little, you papoose them, and it's relatively fast, and we didn't put a tube in, but we just did the probing. Where I am now, we kind of more rarely do procedures on the floor, but it is an option. There are even people who do black tear duct surgery in older children in the office. I think that might be a little bit more cool when you have a 1-year-old trying to do that, but with an infant, we did do this at times, and it was great because then you weren't going to the OR. And obviously that was only if we couldn't decompress them manually. So these are just some pictures showing a probe. If I do have to take the child to the OR, then I put a tube in as well. And then we will have ENT take a look up the nose when we do the surgery, because very often you will see the extension right here into the nose. And we want to make sure that we have popped our way through. Sometimes you can get a false thinking you're through and you're really not. So we have them take a look as well. Interestingly enough, and unfortunately, there's no lack of pathology in pediatrics. My partner had a 16-year-old yesterday who came in, and they, thought she was a preseptal cellulitis. They did imaging, and it showed that it was all the nasolacrimal system. There was this huge sac, and it had actually burst and kind of tracked this way along the lower eyelid. When she took the child to the OR to do the probing, she also had ENT look up the nose, and it was a Dacryocystocele, which had no problems of tearing, frequent infections, nothing, and she was 16 years old. We couldn't believe it. Okay, moving on, orbital dermoid cysts. Again, very common that you will see in a pediatric population. This is probably why I like orbital stuff so much more, because you really see this stuff. Here you'll see that the surface ectoderm becomes trapped in the underlying mesenchyme. It's a choriostoma for board spotter, and it's typically found right at the suture lines. The most common location is the junction of the frontal and temporal bones. And when you examine these children, a couple of things that I do. Here we see, imaging of a dermoid. I don't always image these children. It will depend. If it's, in this classic location, freely mobile, not fixed to the bone, and I can clearly kind of get my hands all around it, then I don't bother imaging the children. And again, these are always things you have to be thinking about, because you're thinking about surgery with kids, which is anesthesia and sedation. And, if you're going to get imaging, you're going to need anesthesia and sedation. So, we really do try to think about that and minimize that. But so as long as I can get my hands around it and it's freely mobile, I don't send them for imaging. If it's fixed, or I feel like I can't get my fingers all the way around it and I'm worried that there could be tracking back further into the orbit, then I have to send them for imaging, because we need to know how far it extends. That's these dumbbell configurations that you can get. And again, on CT, you see these homogeneous low-density cores surrounded by a thin wall. I will say my preference, if I am getting imaging, is I send them for MRI. I don't send them for a CT, and so we avoid the risk of radiation as well. We do recommend surgical excision for these, and the reason for that is that this is just, for any of you who have children, whenever they fall, this is where they hit. My son has stitches right there. I think all of my friends' kids have gotten stitches right there. It's just, that bone is there to protect the eye, but that's where dermoids are, and if you take a fall there, they can rupture, and you can get an inflammatory response. Now, if it happens, you can still take them to the OR and remove them. I've had children where the parents didn't realize anything was there. They fell out of the crib or the bed, and all of a sudden they come in and they have this bump that has not gone away after the fall. And sure enough, what it turns out is that it's a dermoid that they never realized was there, and then with the trauma, it ruptured, it got larger. When we do take them to the OR, we try to excise them completely, and not have rupture. If it does happen, then we just rinse the area copiously. And they're pretty fun surgery. It's when you express that dermoid. In terms of age range, I will say here again, and I work with the parents, but usually when the kids are starting to be more mobile is when I start thinking about surgery. When I'm more worried that, they're starting to walk and get around and they're going to take that tumble, and I worry that then it could rupture. Somewhere around 8 months is, when I start to think about surgery and doing it. The kids will often present earlier than that, but, I'll kind of hold off a little bit. Okay, epibulbar dermoids, two types. We can have a limbal dermoid and a lipodermoid. And again, many of these things, systemic conditions. What we think about here is Goldenhar syndrome. Some other systemic associations are the linear nevus sebaceous syndrome and encephalocraniocutaneous lipomatosis. Classic picture of a Limbal Dermoid. Again, this is a choriostoma. You can sometimes see little pieces of hair coming out of it, and they can occur right on the cornea of the limbus. Really depends on the size and patient family desire. This one is very large. You would want to excise it. Sometimes they're very small. They're just at the limbus, and we observe them. Again, though, these can cause some astigmatism, and so you have to watch for that, even when they're kind of small and located on the limbus. Lipodermoids, here we see that right over here. They involve the posterior orbit primarily, but they may extend anteriorly. Again, you'll see fatty tissue, but without hairs. And again, surgical excision here is very difficult due to, the posterior involvement. Sometimes for cosmetic purposes, you can just debulk what is visible anteriorly. I will say I have one patient who had that done, and done by an oculoplastic specialist, so someone who has a lot of experience in this area, and still, it just kind of migrated forward again. And, I'm kind of just watching the patient because it's small, it's not affecting the vision, and so we just are watching. Rhabdomyosarcomas. This is the most common primary pediatric orbital malignancy. And the average age of onset is about 5 to 7 years, and 90% occur before the age of 16. Classic presentation is proptosis, a very rapid onset within a few days to weeks. They also can have ptosis, strabismus, and localized mass in the eyelid or conge. The other thing that you will classically see is edema or discoloration of the eyelids. Three types that we see are the embryonal, alveolar, and pleomorphic. And the pathology is important because it affects the prognosis. With embryonal being the most severe. These kids get an urgent biopsy, CT, MRI, ultrasound. You need to check for any cervical or preauricular nodes. They get a bone marrow and LP. And before 1965, exoneration was standard. Now treatment with radiation and chemotherapy is the mainstay. Grossly, they're a flesh or yellow-colored neoplasm, not encapsulated, and can often infiltrate the surrounding tissue, and you may or may not see some bony erosion. People always, I feel like the misnomer for this with the boards is that they always are like, is this of the muscle for origin, and it's not. Neuroblastoma. My little one, Mary, will show up in future slides for this topic because she has asymmetric pupils, which kind of freaked me out as a new mom. But I've checked her, and I've made my partners checked her, and we've decided that she just has physiologic anisocoria. But there is a concern there, and you'll see why. This is a malignant tumor of the neuroectodermal cells, and it derived anywhere from the neural crest within the postganglionic sympathetic neurosystem. It's the most common solid tumor of childhood, representing about 9% of all childhood cancers, and 28 to 29% of neonatal malignancies, and a rare cause of orbital disease. But 93% are diagnosed prior to any orbital signs, and 90% of patients with orbital mets have a primary site in the abdomen. So what do we see for orbital presentation? You'll see the sudden onset and rapid progression, again, of proptosis, which can be unilateral or bilateral, and this ecchymosis. This is really classic for neuroblastoma. It's most commonly located in the superior lateral orbit and the zygoma. And why I worried about this with my little one is because these children can get a Horner syndrome because of involvement with the sympathetic chain. And that may even be the primary presentation of the malignancy. So, we very often will see children for pupil asymmetry noticed by either the parents or the pediatrician. And so it's really important to do a good examination to find out, is this truly just physiologic anisocoria, which we do see in a large proportion of the population, or, is it associated with the Horners? And other things, because often these are very small children, you need to think about, is the birth process, was there any birth trauma that could have been associated with damage to the sympathetic chain and the resulting Horners? Okay, so these are my kids again. I don't think you can really see it in this photo, but my little one, Mary, her left pupil is clearly larger than her right. I do believe it's the same in dark and light, although it freaked me out, and she clearly does not have any ptosis of her eyelids. Her movement is full, but I always knew my kids would have an eye diagnosis. I just thought it would be myopia, and so I was kind of surprised to see she had anisocoria. Go ahead.
Question. Do you do testing in the office with drops with Horners?
We do not. I do know of a pediatrician in private practice who will do that. We do not. If I'm convinced clinically that it's a Horners, that there's a difference in the pupil size, worse in a dark setting, that there's ptosis, and the ptosis is going to be subtle because Mueller's muscle about 2 millimeters, so you're not going to see an eye that's halfway down. Then we just send them to oncology and get the full workup. Unless I can document somewhere that there was some sort of very traumatic birth process and that could be the cause for it. And then we're very fortunate in that our oncologists do the full workup for us. Any other questions? No. Okay, well, you guys enjoy your day. I don't know if anyone's joining me. I am heading over to the NICU at Jefferson for ROP rounds. I think I have about 13 babies, so it's going to be a busy morning.